So at this point, we'll go ahead and move into today's topic, which is a follow-up to last month's readmission session. And with that, I'm going to go ahead and hand off to Brianna Gass, who will be starting us off. Go ahead, Brianna.
Thank you, Carmen. Thank you, everybody, for being with us today. We really appreciate the hour that you're allowing us this afternoon to provide some information to follow up on our last session and provide more information around readmissions specific to assessing and addressing the risks of readmissions. Next slide. Our objectives today are as follows. We hope that by the end of today's session, you will understand why unplanned readmissions are a problem. We plan to review with you some major causes of unplanned readmissions, as well as identify strategies and interventions that are most appropriate to address the risks that you identify and overall causes of readmissions. And finally, we hope to have a lively discussion around effective patient-centered discharge plans. Next slide. Our agenda essentially follows the objectives. We will discuss the CMS response to unplanned readmissions, talk about some causes of readmissions and strategies to reduce them. We will end with a question and answer and some interactive discussion, and then we will let you know what is upcoming in our LAN series. Thank you. Next slide. So this slide provides an overview of why even bother to address readmissions. And as you see on the left side, rehospitalizations among Medicare beneficiaries are prevalent and costly. And this is a quote that came from the Massachusetts Medical Society in response to an article that was published in the New England Journal of Medicine by Steve Jenks, Mark Williams, and Eric Coleman. They are all prominent researchers in care transitions, and Mark Williams and Eric Coleman are both developers of very well-known evidence-based methods for reducing readmissions. So they found in the article that they published that 1 out of 5 beneficiaries were rehospitalized within 30 days, and 1 in 3 patients were rehospitalized within 90 days. Obviously, some of these admissions to the hospital may be planned. However, they found that the cost of unplanned rehospitalizations in the year 2004, they estimated that to be over $17 billion. So not insignificant as far as the cost burden this has on CMS, as well as other payers, as well as individuals who end up in the hospital. So Medicare wanted to address these unnecessary costs, and to do that, they enacted a program known as the Hospital Readmissions Reduction Program, or HRRP, to reduce readmissions starting in 2012. This instituted a penalty. So they penalized providers with high rates of unplanned readmissions within 30 days. And they did this for 6 major categories of diagnoses. So you see here 6 listed. And this effort was pretty successful in reducing readmissions up until about 2017. Since then, we've seen readmissions rates generally level off. So we've had a lot of initial reduction, and since then, kind of a plateau in our ability to improve. Next slide. So the Affordable Care Act was another effort to address readmissions. And as part of this, CMS leveraged the QIO program, as well as a program called the Partnerships for Patients, and their Centers for Medicare and Medicaid Innovation to help implement and test models of care that were intended to improve care coordination and as a byproduct of that, reduce readmissions. CMS has also publicly reported readmission rates for hospitals since 2009 on the Hospital Compare website. This site overall was intended to improve transparency and allow consumers of healthcare to make informed choices about the care they receive, as well as to help with kind of benchmarking for overall quality improvement efforts. In addition to this, the HRRP increased their payment penalty from initially being 1%. Beginning in 2014, they went to 2%, and then since 2015, they went to 3%. And they also added COPD and knee arthroscopy to the HRRP program. So those are two other conditions now that are penalized. As noted in the previous slide, we saw a decrease in readmissions, but more work continues to need to be done. This is seen to be an ongoing problem, not only because the burden of cost on Medicare, but because of the adverse effects that readmissions have on patients, their families, and caregivers. Next slide. So I have a graphic here that kind of is intended to depict the breadth and interrelatedness of all the various causes of readmissions. So we know that readmissions are influenced by patient-level risk factors, but also factors that are specific to their providers, issues with the healthcare system, and finally, factors related to their community and social determinants of health. So in this graphic, you see different colors. The green hexagons represent issues with the systems that provide care and services to patients. This includes hospitals and other healthcare providers, but also services such as home medical equipment, nutritional support, and pharmacy. The brown on this diagram represents social determinants of health, including community factors, such as resources that are available in the community, like transportation and housing, as well as social factors such as available caregiver support and networks, including religious institutions and community-based organizations that provide support to vulnerable adults at home. Finally, the blue on this diagram represents individual or patient-level factors that impact the risk of readmissions. So these can include comorbidities, such as chronic conditions, behavioral health issues, and health literacy. I want to emphasize that a patient can be impacted by a single factor that is depicted here, or a combination of multiple factors that interact to compound that patient's overall risk of readmissions and pose challenges to the ability to coordinate their care. So our presentation today will focus mostly on individual factors and how to identify them. Since most of you have a smaller patient population and are able to really address individual needs due to not having hundreds and hundreds of patients to work with, but it is important to be aware of all of the possible factors at play when you assess a patient and address their risks and work to reduce readmissions overall. Next slide. So I want to get an idea of what you see as the major causes of readmissions in your facility. So we have a poll. Francesca, can you please pull up that poll? I'll give you a couple minutes to respond to the poll question, and then we can briefly discuss.
If there are any of you that don't see the poll for whatever reason and you'd like to just type your answer into chat, you can certainly do that as well.
And we do have an other option. If you do select that, we'd love to see what that other is. So please go ahead and enter that in the chat as well. Okay, a few more seconds, and then Francesca, go ahead and close the poll and let us know how people responded. So, okay, well, we see a very clear majority here that note insufficient support or resources for patients at home. I don't think that comes as a surprise necessarily, but it is pretty distinct as far as being the most significant response here. We saw 14% each on inadequate or poor communication between providers, as well as patient risk factors And then coming in last is low patient health literacy and a lack of patient engagement. So that's helpful. We will talk about all of these, but it is helpful for us to know that the resources at home and support seems to be the biggest issue facing your facilities at this time. So next slide. So these next few slides will offer a deeper dive into each of the categories of factors that we just provided an overview on that lead to readmissions. Feel free to chat in any additional factors that you think of or that you've observed in your facility or community specific to each category. Can people hear me?
I can now, Brianna.
Okay, sorry. It looked like I was accidentally muted, or maybe I was muted on purpose. I don't know. Anyway, so here we have our systemic factors of readmission. So these include health system factors. We listed some examples of this, including the insufficient community resources, follow-up care. So there may be a lack of available options for follow-up care in a community, as well as difficulty for patients in accessing that care. And then the available community services such as pharmacy, home health, physical therapy, or behavioral health services that are really intended, that go hand in hand and help the patient be able to manage at home after they've been released from the hospital. And then we have hospital factors, which include lack of communication and coordination between providers, communication challenges between providers and their patients, or perhaps between providers and patients' families or caregivers. And then probably something all of you are familiar with are staffing obstacles. So you may have the best intentions as far as addressing readmissions and providing follow-up care and connecting with patients, but if you don't have adequate staff to do that, it's going to be very, very difficult to carry out those best laid plans.
Brianna, we do have a comment in chat.
Okay, thanks, Nancy.
That says, we do see situations where doctors are on off weeks, where it makes the care coordination a challenge, and of course, also referred care challenges as well.
Great.
There's another, another comment as well that says this indeed it seems to be the going trend in recruiting providers.
Thank you. And yes, those are indeed systemic challenges, and perhaps even more significant now than they have been in the past, and also more relevant for your facilities and communities. Next slide. So here we have the individual or patient level factors of unplanned readmissions. And I mentioned comorbidities earlier that include things like chronic disease, behavioral health, and also issues just related to advancing age that lead to safety concerns in the home, or other issues that aren't necessarily tied to chronic disease. As well as insufficient support at home, and that could be a lack of a caregiver present, or a lack of social network, or potentially safety issues in the home that pose fall risks, things of that nature that are going to vary from patient to patient, but are greatly important in knowing that those are there so they can be addressed and reduce the risks present at home. Health literacy is also just a general unfamiliarity with terminology used in healthcare, obstacles that patients face in understanding discharge instructions, as well as being able to carry out those discharge instructions, and then being able to identify symptoms or issues that come up while they're at home that would require immediate follow-up or a trip to the hospital before things progress to the point where they need to be readmitted. Next slide. And then here we have a lot of information related to the social determinants of health, which are also huge factors in unplanned readmissions. These include things like economic instability, such as homelessness or inadequate insurance, access to education and the quality of the education provided. Sometimes patients may have impaired ability to care for themselves or just poor cognitive status that makes it difficult for them to understand and follow through with instructions. We also have the neighborhoods they live in and the built environment. So there may be just really inadequate or a complete lack of transportation that makes it very difficult for them to attend follow-up appointments. There's also prevalence of asthma or air quality problems or other issues that may exacerbate symptoms once they get home. And then health issues of healthcare access and quality. So we talked before about the availability of health services. That could also include distance to travel to those health services, the ability of ordered DME to arrive at their home when it needs to, access to physical therapy, pharmacy services, and when those things are open, et cetera. And then finally, the availability of other support, such as nutrition and meals, and other assistance, such as perhaps they need help paying for utilities in order to keep their electricity on so they can use their oxygen tank or monitoring devices or what have you. So all of these come into play when it comes to driving readmissions. Next slide. So I'm going to pass this over to Sarah now that we've covered all the different causes of readmissions. She is going to walk us through how to identify and address the risk factors for readmissions.
Thank you, Brianna. And yes, we're going to look at some of those factors that play into unplanned readmissions that Brianna has already reviewed in the previous slides. But here are 3 of those strategies that we have selected to look at. Obviously, there's a lot more as we had addressed earlier, but we thought some of these were good to review for Indian Health Service hospital settings. So how can patients who are at high risk of being readmitted be identified so that their further readmissions can be avoided, and also so that your discharge process can be better enhanced and be more thorough? So one strategy is identifying those patients that are at risk and most frequently seen, so that you have a better understanding of what that type of patient is and what are the type of interventions that you can do to avoid their rehospitalization, and what the staff can focus on so they can match those needs that have been identified. So the use of predictive models can flag patients at risk for readmission. So a risk assessment, and then in some cases, the second phase of stratification can provide a systematic way to identify and predict those patients who are high at risk or likely to be high risk, and it will benefit and target their care management resources to prevent these readmissions. So risk assessment tools are helpful for identifying around the medical and chronic complex factors, but also, as we reviewed, healthcare providers should also remain really astute to the patient's continuum of care, and especially what they had noticed during their inpatient care, so that they have clues to the socioeconomic and their personal factors that could be a signal in increased risk for readmission. So we'll look at some of those factors beyond the medical factors, like the community-based resources, focusing on the patient needs in their transition of care. And lastly, we'll look at a more patient-centered component of your discharge planning process. Next slide, please. So we're going to look first at a risk assessment tool. The LACE tool was one that was chosen. There are a number of them, but we chose this because it's widely used, and it's a validated tool and simple and adaptable. So multiple studies have evaluated the predictive value of this LACE index, and it's shown that a moderate to high predictive value it holds with identifying patients at risk for readmission within 30 days. And then it also has a high predictive value for identifying patients that would return to the emergency department. Again, the letters of the acronym identify topics used in determining the LACE score. And these factors are pretty similar across many of the risk assessment tools. Next page, please. So scoring is based on 4 specific attributes, and it results in a final score, which will signify your patient as high, medium, or low risk. The first attribute is length of stay, and the number increases and the score increases based on the days that the patient stays in the hospital. The second attribute, acuity of the admission. So patients admitted as inpatients are given 3 points, and the patients that are placed on observation would be given 0 points. The third attribute, the Charlson comorbidity index, is assessed by the type and the number of comorbidities, and this is cumulative up to a maximum of 6 points. The fourth component of LACE emergency room visits is just what it is. How many visits have they had in the previous 6 months? So these scores are added, and the sum of the score of risk readmission greater than 10 signifies that a patient is at high risk. What your hospital care team staff could do is set up standard interventions that are applicable for each of those categories of high, medium, or low. So for example, some of the interventions you could do for high risk are making sure the case manager and the care team meets with the patient during their hospital stay, gathers really important information prior to their discharge. A pharmacist reviews medications prior to discharge, so it's really understandable what that patient needs to do. Looking overall, the case management or their care team could actually be on board to determine what kind of care management plan there is. And then also for this high risk, you'd probably want a follow-up appointment within X or 3 business days, say. So whereas a protocol, like if you were a moderate risk of a score between 6 to 9, maybe a follow-up is in 7 days. So it would be these interventions based on the risk. So this LACE tool is in a table format that you could use by paper and pen, or it's the logic of it can definitely be implemented within an EHR system. Next. So this is a screenshot of a guide that during the first PATH contract was developed, which gives an overview of the technical tools available within the Indian Health Service RPMS system. And this is for management of high-risk patients. So this guide, and there is also a supplementary video that demonstrates how 2 facilities, one was Chinle Hospital and the other was Northern Cheyenne Lane Deer, which is actually a clinic, but they created a risk assessment logic, and then they also added on that stratification factor. And they did this within the iCare system. One of the facilities chose to follow a modified version of the LACE, and you can see that on a screenshot of that iCare on the right-hand side. And the other facility implemented their own risk logic, which is the capability within iCare. So again, there's many ways that a facility can risk assess and stratify their patient population. And this would be a guide that a clinical application coordinator could use to follow to make templates and make this applicable to your specific hospital population and needs. And I see that Nancy has already put those links on there. It is on our CoMagin PATH site right now, and that's where those links take you. Thank you. Next slide. So healthcare organizations are pursuing partnerships with community-based organizations. And as you can see on this word cloud, I kind of put as many as I could think of, but we certainly want to hear back from you, because in the poll, we noticed that this is a factor that is potentially an issue for readmission, is that we don't have that link with those community resources out there. So would you please chat in some of the effective community resources or services that you are using for your patient population? And if you wouldn't mind, like where, what facility you're from, that would be great. I'm going to extend this out also to any of the PATH staff that works with hospitals. If you know from discussions or working with them of some areas that would be beneficial or that they are using very well, please chat that into. Wow.
Sarah, we're getting a few that are coming in.
Great.
Cultural traditional healers, community health workers, community health resource individuals, CHRs, for the Cheyenne River Health Center. I know we have those in the area where I live as well. Caregiver support, transportation, community health representatives, tribal programs.
Great. Alzheimer's, thank you. Thank you, thank you very much for chatting in. There are some great ones, and I am, Cecilia, I'm not sure where you are from, if you could chat that in, but the cultural traditional healers, I left that off, and that is so very, very important in your communities. And we certainly have to look into that a lot more, and we'll be reaching out to you most likely. So, and then community health workers, transportation, tribal programs. Yes, having those tribal programs and having that connection and understanding between them is really important. So thank you very much for participating in chatting in. So locally based community resources, as we're seeing, are coming up in the chat. They are very well positioned to identify and address these social needs, since they are closely connected to the populations they serve. And many of the staff in the hospitals in the communities are familiar with their environment, and they live and work in that environment. So thank you again. Next slide. So we do know, and that community resources are really important. So an effective use of them is using those existing relationships that you already have, and then also really looking out and trying to identify and develop new resources to fill in gaps that you may have in the services that your patients need. Map out and create an inventory of these community-based resources. So this could be used and made readily accessible for the staff in the hospital, for discharge planning, for your care transition planning within the clinics. But this will help you tailor needs of your patients that are at risk, or just that in general for your patient population. So some suggestions for identifying and connecting with community resources are within your cross-continuum team. Just make an effort that everybody looks for these resources and brings them to the table. Care coordinators, public health nurses, pharmacists. Make it really key in your facility that this is what we're looking for. Looking up in your own state health and human services departments, what Medicaid programs they have, development disabilities, they may have state improvement plans, substance abuse, etc. So you would identify those, but find those key contacts to see if there are connections that you can make and that will be worthwhile. And then a formalized process within your hospital transition discharge planning could definitely enhance and guide those providers and the care team to connect patients with care needs. That coordination between patient and referrals is very important, and that referral can be a specialist, or it could be special treatments like patient care as far as physical therapy. But what you could do is put agreements together that would explicitly show the responsibility of tasks to care for that patient, including like the scheduling of follow-up appointments, treatment plans, what's going to be our method of communication between the patients and us, and what type of engagement are we looking for. I see that Nancy already posted in a chat Transitions of Care Planning Guide. This was developed by the National Council on Behavioral Health Transitions, but I had looked at it and I thought there were some really good ideas in the area of behavioral health that could definitely be applied within all areas of care. Next slide.
Sarah, this is Nancy. And
yes.
you know, when we were practicing this, I kind of had mentioned this to you as well, but you say something on this slide that just is profound to me, and it's just mapping out, you know, not only your highest priority or highest readmissions diagnoses. You know, most facilities, when we've asked you guys before, you know, what are you all know, these are the top 5, top 3, top 10 diagnoses. And then kind of like Sarah recommended on this slide is just kind of create that inventory of how are we impacting this diagnosis and ensuring that this type of a diagnosis patient, you know, obviously there are other things that are individual, like Brianna spoke earlier on this slide, that will also impact that. But I can't help but think that a true map or a facility guide to say, this is what we are doing to try to reduce these readmissions in our top diagnoses. So I think that would be great. And I can't help but think that a surveyor would appreciate that as well, just to say, wow, this is what they're doing to impact their readmissions.
Thank you. Thanks, Nancy. And I thought that was kind of a good idea too, because everyone has somewhere to go. So, but thank you. Then we are on, our next slide. So a standard process and template for discharge planning is key also, and it helps ensure that there's components that are necessary and that they are completed for a safe transfer home for your patient. So the doctor authorizes patient's release from the hospital, but that actual process can be done by a designated staff, such as social worker, nurse, or case manager. Definitely, it's even for all patients, but for most complicated medical conditions, it's really important that there is that team approach to their transition in care. Another toolkit by the Agency of Healthcare Research and Quality. It's called Designing, Delivering Whole Person Transitional Care and the Hospital Guide to Reducing Medicaid Readmissions. And this toolkit looks at the discharge process and kind of has a checklist based on CMS, conditions of participation. And it could be a very good reference for you in developing what is needed in that discharge plan. And in general, a recommendation is to write your it's to have that written discharge process, regularly review readmissions to identify any root causes of the readmissions, and use those insights to continually improve the discharge process. So a discharge plan should identify care you need after you leave the hospital and what that patient's self-management goal. They must leave with an understanding of how to manage their medical conditions, such as medications, understand their diet, and any restrictions they have on activity. In one of our hospitals, the outpatient nursing manager noted that medication management was a big, significant issue in readmissions. So it's very important that either the patient or the caregiver, or both definitely, should understand, first of all, the details of the medication, why it was prescribed, the purpose of it, and also know their symptoms and how to use that prescribed medication. So it's becoming more common for medication review to be completed by that clinical pharmacist. The patient and caregiver need instructions on the medical equipment, and I think Brianna addressed this before too, follow-up visits or referral care from physical therapy, etc. What do they need during that recovery process? So that should be included so that they have referenced the whole care for that patient. And we did talk about health literacy. Not all patients do have the same ability to learn and implement these techniques. And so it's really important that in the use of providing education care, that the medical jargon is left out or given in a more understandable language, and that you have educational materials that are easy to read and incorporating some images and asking open-ended questions such as the use of a teach-back technique so that your communication tools can validate a patient's understanding of instructions. All right, we'll go on to the next slide. And Brianna is now going to walk through an exercise to help think about how to address these specific risks that we have discussed so far.
Thank you, Sarah. So as you see here, we've talked about the various kind of categories of risk that exist, but we also listed here on the left side or the left column some risk examples that are a little more specific. And the bold italicized ones, those were ones that came out of your responses to the readmissions assessment survey that I believe was done back in March. Anything here in orange are individual items that the LACE assesses for. And then we also need to think about the systemic and environmental factors that could lead to readmissions, and these are listed as the last 3 items on this list. And as you noted in the poll earlier, access to resources seems to be a huge issue for all of you, or most of you, and the facilities you work in. So what I'd like to do is think about, if you were to see some of these risk examples, how would you address those specifically? So on the right-hand side, we have potential interventions, and these are all fairly common ways that different facilities I've worked with and the QIO programs have worked with and hospitals have put in place to try to improve care coordination, improve the discharge process, and ultimately reduce readmissions. Some of these apply to many of the different risks, so they would help address many of the risks that are listed here. And we also could address risks using a combination of these potential interventions. So I just wanted to take a few minutes to think through how we might go about matching that up. And feel free to enter your thoughts in chat or take yourself off mute and respond by phone. I can kind of get started. So we see access to resources listed as an example of risk, and this might be an area where we can refer to other support services that do exist in the community, but also leverage case management to be able to ensure that the patients that are referred to those services do in fact access them once they have left the hospital. So I'd like to hear some of your ideas that you would take any of these risk factors and how you would address them, and why does a certain intervention make sense for that risk factor? So I'll walk through another example with COPD or other respiratory diseases. And this might be an example where a follow-up call would be helpful, just to see how a patient is doing once they arrive home, make sure they have everything they need in place. The follow-up call could follow up on referrals for durable medical equipment. If a patient has diabetes, for example, we might refer to diabetes management education. You see that in the second to last bullet there. So just thinking about, a specific diagnosis and what would be most helpful in either helping that patient manage their illness at home or reducing other risk factors that are at play.
And Brianna, in looking at geography, one thing I have seen hospitals and more specifically, surgeons and physicians do is address the fact that certain things aren't available in certain areas. So physical therapy is often not available in rural areas, or it's so hard to get to that it's really just more difficult for the patient to do that. And they may skip it. So those physicians have, in some cases, really worked hard on modifying, creating exercise plans or other plans to help them do what they need to do at home, rather than have to try to travel extremely long distances or do nothing at all.
And I love that you said modify, because I think there are also ways where these interventions can be adapted in order to a better fit the specific community or environment a patient is going home to. So we may have, in a urban environment, it may be a simple fix to schedule a follow-up appointment with a physician before that patient leaves the hospital. And you can more or less count on that patient being able to get to the hospital. But if we're talking about traveling long distances, we may want to think about whether a telehealth visit might be more appropriate, or whether a phone call could cover some of the items that would happen in that follow-up visit, so that patient isn't faced with a burden of having to get to their follow-up care. So there's always, I think, room to adapt and think about those things. We have the list of community organizations. That's the fourth bullet from the bottom. That can be provided to patients, but also can be provided to their physicians or the discharge manager at the hospital, so that they are aware of the resources that are available, and can think about what maybe to match patients up with and set up before they leave. And then the follow-up call can help to follow through on whether that patient actually accessed that service that they were referred to. So there's a lot of different ways to kind of think about and combine these different interventions in order to best address the needs of that specific patient. But I wanted to make it very clear that there's no one-size-fits-all solution. Different patients are going to benefit more from different things. And we also have the ability to adjust and adapt to best suit the needs and situations in our facility or community.
Brianna, this is Nancy, and I like that you said that there's a no one size fits all. And so I wanted to bring up, we've all been doing these follow-up phone calls, right? And we've been really good about getting the appointments scheduled and stuff. So you can get a phone call, if you're able to reach them by phone, get something scheduled in the books. But then what happens in 7 to 10 days when that patient, for whatever reason, can't get to that appointment, has troubles or issues? Is there a process that any of the facilities have in place that help with that gap in between the follow-up phone call and the patient actually making it to their follow-up appointment?
Nancy, are you asking me, or are you asking the facility, our audience to respond?
Yeah, I'm just asking the entire, the audience out there, just to say, well, how are you utilizing your community resources for that particular patient who might struggle between the discharge and the very important appointment they may have?
And I'll just add, that's where the plan of care, especially when it's developed with the engagement of patients and their family caregivers, becomes really important. And as well as that red flags education, because I think that gap may be up to a week that they're home before they have a follow-up visit. or even a follow-up call. And instead of waiting for that call, it would help to know like a list of symptoms to look out for, and they can look at that and say, hey, I'm not experiencing any of these symptoms, so I'm okay. Or they can look at it and say, oh, I've been short of breath, and that seems to be something I'm supposed to call my doctor for. So they know, they're given sufficient information to know when to reach out themselves if that follow-up call or follow-up visit hasn't happened yet.
Well, and another thing that I have seen in the past is really just kind of getting creative, where, as Sarah just said in chat, you know, those transportation programs often aren't available in rural areas, but sometimes that plan of care might include, you know, beyond just family caregivers, but neighbors. You know, if we can arrange ahead of time for a neighbor to check in and give them a little information, or perhaps be one of those ride providers, that can be just that tiny bridge that helps someone get what they need.
That's a really good point. Okay, well, I'll go on to the next slide. This just provides some overall resources and links, some of which we touched on earlier in the presentation, but maybe good for you to look at in order to research different interventions that are available, particularly READ and the BOOST program at the bottom of this list. Those are toolkits. They're great if you can do everything in the toolkit, but they're meant to be looked at, and you select and pick and choose what seems to make the most sense. But those are really great resources, along with the others that are mentioned here, such as AHRQ's Whole Person Care Toolkit, and the Care Transitions from Hospital at Home Ideal Handbook is also very helpful as well. Next slide. And I'll just note that we will make these slides available to all of you, and these are links that you can access directly from the slide deck once it's received. So that is the end of the content that we had around readmissions reduction, but wanted to give you all an opportunity to ask questions or make note of anything that we didn't talk about that would be important for our audience to know. And again, you can enter a question into chat or feel free to take yourself off mute and ask directly. And Nancy entered into chat the question, what are beneficial tools that you are using for discharge planning? So is anyone using the tools that Sarah mentioned earlier, or any other tools that you found particularly helpful?
You know, this is Nancy, and while we're waiting for somebody to type something in or feel brave enough to come off of mute, we recognize we're preaching to the choir with all of you, and that, you know, you've seen lots of your patients come back to the hospital for lots of different reasons. And so if there's anything that you've done in your facility that's been creative or innovative and seems to be working, and you'd like to share that, we would love to hear that.
Hi, can you hear me? This is Jennifer.
Yes, thank you.
I'll break the silence. How about that?
That's great.
We use the LACE tool here at GIMC, and we've done it for over 4 or 5 years. I'm gonna say since our last utilization nurse was here. And it really does help organize our case managers. We have inpatient and outpatient, so the inpatient case managers are the ones that are utilizing the tool. As far as other discharge planning, we were working with PATH LAN 3 I'm gonna say 2 years ago on my behalf, and we implemented the post-discharge call in both ED and inpatient. It's been quite an experience just trying to get the volume completed, especially in our ED. Our emergency department, we only have one case manager there. But we are focusing on our readmission and how it's affecting that in the ED and also in inpatient, our readmission rate. So.
And Jennifer, just a follow-up question, as you noted, you only have one case manager in the ED. How do you prioritize those discharged follow-up calls? Is there a kind of a standard process in place where you decide if there's a limited number of calls that can be made, who gets them first?
Yes, great question, because we see almost 3,000 patients a month. So our one case manager utilizes the acuity level system. And of course, we take on all the patients who are not discharged home. We only focus on the ones who are discharged home, not to any other facility or transfers. And the biggest focus she does is in our category 3s and 2s. Definitely the level 2 acuities in our ED, because they are the sicker ones. Most of them get transferred out, but some of them we do send home. So she mostly tries to capture that group.
Great, thank you. That's really helpful.
That's a hop in ER. Need to get that case manager a helper.
Yes, we know. We've been trying to look at other hospitals. And actually some facilities utilize RNs on their downtime in the ED to make those post-discharge calls.
That's a great idea.
Okay, well, feel free, all of you in the audience or PATH team members, to enter more ideas you have as far as tools for discharge planning or ways you've mitigated challenges with implementation of some of your planning tools in the chat. And I will go ahead and move on to the next slide as we're getting close to time. We have another poll question here, and this will really help us determine, what you all found most helpful and how to follow up with information going forward. If you could take a moment to check the 2 items here that would be most helpful in improving your discharge planning processes. And Francesca, if you could go ahead and close out that poll.
We still have a few coming in.
Okay. Okay, and once again, we have a kind of overwhelming majority with a single answer, which is incorporate causes of readmissions and interventions into effective patient-centered discharge planning. That's great. I think that is something we are going to be working on. And that was followed by how to match meaningful interventions with the identified causes of readmissions. I think those 2 items are pretty interrelated. So that is helpful to know. Thank you all for completing that poll. Next slide. So I will pass it back to Carmen to go over some of our upcoming events and wrap up our LAN event today.
Okay, great. So looking ahead, in next month's LAN, we are going to be discussing trauma-informed and resiliency-minded approaches to providing culturally appropriate care for our populations. So next Thursday, the 29th, same time. And we are also continuing our accreditation, certification, and PCMH huddle series. That's also posted on the IHS quality portal too. So you've got a couple of places to find that link. These are brief huddles. We have 30 minutes of a huddle on a specific topic and then a quick office hours. And really those office hours are open to anything, any kind of questions that you have about accreditation, certification, etc. And let's go ahead to the next slide. And as always, you know, we got some answers from you in the poll. We're trying very hard to make sure that these sessions are very meaningful for you and provide you with good information. So we do have a feedback assessment that Nancy has dropped into chat. We definitely appreciate it if you would give us some feedback, and we will continue to incorporate that into our LAN sessions. So we are very close to time. Thank you so much for your participation, and we hope this was helpful for you, and we will hope to see you next month at PATH LAN. Have a wonderful rest of your week.